Welcome, everyone, to the Ink and Air channel from OptimalAnesthesia.com. We're doing a deep dive today into, well, a really compelling medical challenge. Anesthesia for a 13-year-old undergoing surgery for severe scoliosis.
It's a fascinating area. We're going to explore the complexities, when you have these significant spinal curves, thoracic and lumbar, and how the team ensures safety.
Exactly. And just a quick heads up for you listening, if you want to dig deeper into the references for what we discuss, OptimalAnesthesia.com will have those available starting in June 2025.
Right, good point. Because this really involves a deep understanding of physiology and careful planning. It's absolutely critical.
So maybe start with scoliosis itself, just a quick refresher.
Sure. So scoliosis, many of you know, it's that sideways curvature, but also twisting of the spine. Some cases are mild, don't need much intervention.
And not this one.
No, definitely not. When curves get severe, we're often talking, over 7-degree surgery becomes a really important option. It prevents worsening, helps with pain, and can even improve breathing if the chest is restricted.
And this patient's curves.
They're significant. An 80-degree curve in the thoracic spine, that's the middle back, and a 90-degree curve down in the lumbar spine, the lower back.
Wow. 80 and 90. That really paints a picture of the challenge.
It does. It highlights the complexity right from the start.
And you mentioned OptimalAnesthesia.com has this helpful analogy, the Ink and Air channel. It's supposed to help frame the anesthetic side of things.
Yes, it's a great way to think about it. It simplifies the two absolutely vital functions we have to protect during this kind of major surgery.
So break it down for us. What's ink and what's air?
Okay, so ink, think of that as the blood flow. It's carrying everything, vital oxygen, nutrients, medications. We need that ink flowing properly to all the organs, especially the brain, and crucially here, the spinal cord.
Got it. Ink is blood flow delivery system.
Exactly. And the air channel, well, that's the respiratory system. Lungs, airways, bringing oxygen in, getting carbon dioxide out, that constant gas exchange that keeps us going.
Makes sense.
And in a surgery like this, with scoliosis in the mix, both of these channels, ink and air, face some pretty unique and significant challenges.
Okay, let's bring it back to our specific patient. 13 years old, those severe curves, undergoing posterior spinal fusion, so surgery from the back to correct and stabilize.
That's the plan.
Her stats beforehand. Breathing rate 18, oxygen 99% on room air, CO2 is 32. Good activity tolerance, too, even though she declined formal lung tests. That sounds pretty good on the surface, doesn't it?
It does seem reassuring, right? Her body is clearly compensating well at rest. She's getting enough oxygen in, enough CO2 out.
A sense of butt coming.
Well, yes. Those severe curves, they tell a different story about her underlying reserve. That 80-degree thoracic curve, it's definitely impacting her air channel mechanics already.
How so?
It twists and compresses the rib cage. Her lungs just don't have the normal space to expand. So her total capacity, her efficiency, it's likely reduced, even if she seems okay just sitting there. It's like, I'm starting with a tank that's not quite full.
Okay, so the air channel is compromised by the thoracic curve. What about the ink channel and that 90-degree lumbar curve?
Right. That lower curve, the lumbar one, can put pressure on the big blood vessels in her abdomen. Think about the inferior vena cava, the main vein bringing blood back from the lower body.
Okay.
Even before surgery, that curve might be subtly squashing it, hindering blood return to the heart. It might not be obvious when she's just lying down, but it affects her baseline ability to regulate blood pressure.
So even though she looks stable, her body's already working harder just to maintain things.
Precisely. Those deformities mean she's less resilient, more vulnerable to the stresses of anesthesia and this really major surgery.
Let's dive into that more.
Oh,
How exactly do these curves mess with the ink and air channels during the surgery? You said thoracic affects air, lumbar affects ink.
let's start with the air channel on that thoracic curve. It physically restricts things. Imagine your rib cage is like a bucket, and the lungs are inside. If the bucket is twisted and squashed,
The lungs can't expand properly.
exactly. It leads to what we call restrictive breathing. Less air in and out with each breath. It's like trying to inflate a balloon that's stuck inside a tight box. Very difficult.
Okay, that makes sense. And the ink channel impact from the lumbar curve, especially you mentioned when she's positioned face down for surgery.
Yes, the prone position is key here. Lying face down already puts some pressure on the abdomen. At a 90-degree lumbar curve, maybe some muscle tightness, that abdominal pressure goes up.
And that compresses things.
It can really compress those big abdominal vessels,
Right.
especially the inferior vena cava. We talked about that one, bringing blood back.
Right.
If you squeeze that vein, less blood gets back to the heart. Less blood returning means less blood the heart can pump out.
Leading to low blood pressure, hypotension.
Potentially, yes. And that means less oxygen delivery everywhere, including that very sensitive spinal cord we're operating near. So anesthesia has to actively support both channels, manage the breathing despite stiff lungs, and keep that blood pressure up to perfuse the spine.
You mentioned her lung compliance was low, 19 millijoule need HO.
Hmm.
Can you unpack that number? What does compliance mean here?
Yeah, compliance is basically a measure of how stretchy or easy to inflate the lungs are. Think of it like elasticity.
Okay,
A normal kid's lung is pretty compliant, maybe 30 to 50 in those units, like a fairly easy balloon to blow up.
but hers is 19.
Right. Much lower. It means her lungs are stiff, less flexible, more like trying to inflate a really thick, rigid balloon.
And that's because the thoracic curve is restricting them.
Exactly. It's restricting the chest wall movement and the lungs themselves. Because they're stiff, we have to use higher pressures on the ventilator to get enough tidal volume into them during surgery.
But high pressures are risky?
They can be. Too much pressure can cause barotrauma, basically, lung injury from overstretching, so it's a real balancing act.
How do you manage that?
We watch the pressures very closely. In her case, the peak pressure needed was around 22 centimeter H euro after intubation, which isn't too bad, but we monitor it constantly. And we might need to adjust the ventilator settings during the surgery, especially if the surgeons are working on the thoracic part of the spine, as that manipulation can change the lung mechanics moment to moment.
A constant balancing act for the air channel. Now back to the ink channel. That 90-degree lumbar curve, prone position, risk of low blood pressure. What else is going on cardiovascularly?
Well, that lumbar curve, increasing abdominal pressure and squeezing the vena cava, is a big factor for reducing preload, the amount of blood returning to the heart. Prone positioning makes that worse.
Okay.
But there's also the effect from the thoracic curve on the heart. Remember how it restricts the lungs? That can increase the resistance in the blood vessels within the lungs, pulmonary vascular resistance.
Making it harder for the heart to pump blood through the lungs.
Exactly. Specifically, the right side of the heart, the right ventricle, it has to work harder against that increased resistance. Over time, this can actually strain the right heart.
So you've got potentially less blood coming to the heart because of the lumbar curve and vena cava compression, and the heart has to work harder to pump blood out through the lungs because of the thoracic curve.
You've got it. It's a double whammy, potentially. Reduced preload coming in, increased afterload or resistance going out for the right heart.
How do you manage that ink channel challenge?
It means we absolutely have to maintain adequate blood pressure. We use vasopressors, drugs like phenylephrine, quite readily to constrict blood vessels and keep the pressure up, ensuring that spinal cord gets enough blood. But we also have to be really careful with IV fluids.
Why is that? Too much fluid's bad.
It can be, especially for the right heart. If it's already strained from pumping against high resistance in the lungs, flooding it with too much fluid volume can actually make things worse, potentially leading to right heart failure. So it's judicious fluid management, enough to support pressure, but not too much. And constant vigilance, especially in prone.
And the surgery itself actually straightening the spine, that must add another layer of complexity.
Oh, absolutely. That's a critical phase. The surgical maneuvers, distraction, derotation, they physically move the spine.
Which could affect blood flow or breathing.
It could. Straightening the spine might stretch blood vessels or change pressures in the chest cavity. The biggest concern, though, is the blood supply to the spinal cord itself. If that perfusion drops during the correction,
Urological injury.
that's the risk we guard against vigilantly. And that's where intraoperative neuromonitoring, or IONM, is indispensable.
Tell us about that. How does it work?
It's a system where we place electrodes to constantly monitor electrical signals traveling up and down the spinal cord and to the brain. We track both motor signals for movement and sensory signals for feeling.
Like an early warning system.
Exactly. If those signals start to fade or change significantly, it's a red flag. It tells us the spinal cord might be under stress, maybe not getting enough blood or being stretched too much.
And if you see those changes?
Immediate action. We work fast to optimize both ink and air. Boost the blood pressure, get more ink flowing to the cord, double-check the ventilation, ensure optimal air and oxygenation. And we talk to the surgeons immediately.
So they might need to adjust.
They might need to ease off on the correction temporarily or change their approach to relieve any pressure or stretch on the cord.
And you mentioned a specific type of anesthesia helps with this monitoring.
Yes, we typically use TVIN total intravenous anesthesia, usually with drugs like propofol and remifentanil. The key thing is it allows us to avoid using muscle relaxants.
Why avoid those?
Muscle relaxants interfere with the motor signals we're trying to monitor. Without them, the IONM gives us a much clearer, more reliable picture of the spinal cord's function throughout the entire correction process.
Okay, so pulling it all together, what are the key steps, the specific strategies during the operation to keep those ink and air channels safe?
Well, it starts pre-op, noting those baseline numbers RR, SpO2, CO2. They give us a sense of her reserve. Then, after induction and intubation, we go on to ventilation, usually pressure-controlled given the likely low compliance.
Right, if stiff lungs.
We set a target tidal volume, like 325 milliliters in this case, and watch the peak pressures needed to deliver it. Keep those pressures safe. Continuously monitor CO2. That's the air channel management.
And for the ink channel.
Maintain that MAP, mean arterial pressure, above 65, ideally 70 millimillimeter Hg. That's our target for spinal cord perfusion. Use vasopressors like phenylephrine as needed, especially when prone. Anticipate blood loss, maybe 700 to 1,000 milliliters here.
How do you manage the blood loss?
We use drugs like tranexamic acid to reduce bleeding, and often salvage collecting her lost blood, washing it, and giving it back to her. Minimizes the need for donor blood.
And all the while, eyes glued to the neuromonitoring.
Absolutely. Any alarm, any significant change in those signals triggers that immediate response. Boost the MAP, check ventilation, communicate with surgery. It's a constant feedback loop. Monitor, anticipate, respond. Keep the ink flowing, keep the air channel clear.
You mentioned other cardiovascular issues too, beyond just blood pressure. Could you elaborate a bit more on those, like the right heart strain?
Sure. So that increased pulmonary vascular resistance we talked about from the thoracic curve squashing the lungs, that chronicity can definitely put a strain on the right ventricle. In some severe, long-standing cases, it can even lead to pulmonary hypertension.
Okay.
Then there's the preload reduction from the lumbar curve compressing the vena cava, especially prone. Less blood returning. Also, sometimes in chronic conditions like this, the body's natural blood pressure reflexes, the baroreflexes, can become a bit sluggish.
Meaning the body doesn't react as quickly to pressure drops.
Exactly. It makes managing blood pressure more challenging. We have to be more proactive. You might also see some diastolic dysfunction, the heart not relaxing and filling properly between beats, maybe due to those altered chest and abdominal pressures.
So the management really boils down to
Vigilance. Monitoring MAP constantly. Using vasopressors proactively. Being really careful with fluids to avoid overloading that potentially strained right heart. Watching closely during the surgical correction for any sudden hemodynamic shifts.
any other rare risks.
Well, there's always a small risk in major spine surgery of venous air embolism, air getting into a vein. It can be serious. We often use a special Doppler ultrasound probe over the heart, a precordial Doppler, to listen for the characteristic sound of air bubbles, giving us an early warning.
Okay, so surgery's done, patient's heading to recovery. What are the concerns for the ink and air channels after the operation?
Post-op, the focus shifts slightly, but remains crucial. For the air channel, the big risks are hypoventilation, breathing too shallowly, and atelectasis, those collapsed air sacs in the lungs.
Why do those happen?
Partly lingering effects of anesthesia, but mostly pain. It hurts to take deep breaths after such a big operation, and the lungs might still be a bit restricted even after correction.
So pain control is key for the air channel post-op.
Absolutely critical. We use multimodal analgesia, maybe an epidural catheter placed during surgery, or a PCA pump the patient controls. Good pain relief allows them to breathe deeply. We also push chest physiotherapy and using an incentive spirometer, that little device you breathe into to pop open the lung.
Makes sense. And post-op ink channel considerations.
We watch for fluid shifts. The body's fluid balance can change quite a bit after major surgery and blood loss. Also, potentially delayed hypotension. Now that the lumbar curve is corrected, the pressure on the vena cava is relieved, which changes blood return dynamics. We need to ensure blood pressure stays stable.
How do you help with that?
Monitoring, of course. Careful fluid management continues. And getting the patient moving as soon as safely possible, early ambulation helps venous return. Keeping the head of the bed slightly elevated can also be beneficial.
And her good pre-op function helps here too.
Definitely. Patients who start with better baseline respiratory function, like her, generally tend to recover their breathing capacity more quickly post-op. We still watch closely for any issues, maybe needing some non-invasive ventilation support like CPAP or BiPAP, but needing reintubation is thankfully pretty uncommon.
This has been incredibly detailed. If you had to distill it down, what's the main takeaway from using that ink and air channel analogy for this kind of surgery?
I think the real value of the analogy, even though it sounds simple, is that it keeps the focus laser sharp on the absolute fundamentals. Our job boils down to ensuring two things: continuous, adequate delivery of oxygenated blood, the ink everywhere it needs to go, especially the spinal cord, and maintaining effective breathing the air channel to get that oxygen in and CO2 out.
Keeping those two things balanced despite all the challenges.
Exactly. Balancing them against the scoliosis itself, the prone position, the surgical manipulation, the blood loss, the anesthetic drugs. It requires really meticulous planning, nonstop monitoring, and constantly anticipating what could go wrong with either channel and being ready to fix it instantly. It highlights the precision needed.
And you mentioned teamwork earlier. That seems vital here.
Oh, absolutely essential. You can't manage this safely in a silo. It's constant communication, constant coordination between anesthesia, surgery, nursing, neuromonitoring techs. Everyone plays a critical role. It's a true team sport.
Well, for everyone listening, we hope this deep dive gave you a clearer picture of the anesthetic challenges and strategies in severe scoliosis surgery. Remember to check out optimalanesthesia.com for more insights.
And those references will be up from June 2025 if you want the evidence-based details.
Please do subscribe if you found this valuable, and let us know your thoughts on social media. We really value your engagement.
Yeah, it's great to keep the conversation going. There's always more to learn.
It really is quite something, isn't it? When you stop and think about the sheer amount of knowledge, skill, and real-time coordination that goes into navigating a case like this safely, it just gives you such an appreciation for what goes on behind the scenes to care for these young patients. Something to ponder.